Committee will come to order. Thank you for your patience while we conducted a series of votes on the floor of the House of Representatives. We're going to pick up where we left off and hear testimony from Mr. Warren. You may proceed. Thank you.
Thank you, Mr. Chairman and members of the committee. It's on behalf of Baltimore Substance Abuse Systems, which is the funding, strategic planning entity that funds over 60 drug treatment programs in Baltimore City, treats 21,000 people. I appreciate sharing the story of what we've been able to accomplish with medicated assisted treatment, which is one aspect of my talk. The second is to describe some of the experiences I had as Director of Substance Abuse Treatment Services for the state prison system, and how we can use medication-assisted treatment to better link people into care upon release. I was struck very much by the quality of the debate that happened prior to the break, and there's several key philosophical approaches that I use in my work that I've learned over the years of counseling people suffering from addiction. And that is, it is very, very important to take advantage of that, what I call motivational moment that an individual has that says, I have a problem, and substance abuse may be one of the root causes of it. That's the first piece. The second is that recovery takes a long time. That phrase, it takes a village, is very, very true. What we've decided to do in Baltimore is begin to change the way we even describe treatment. We prefer a language that says continuity of care, that someone comes into an emergency room because they have liver pain. They then get into one type of substance abuse care, transition to another type of substance abuse care, and then transition to another type of substance abuse care. The end result may be recovery coaches that aren't sponsors, aren't counselors, but really help that person better integrate into society. We think medication-assisted treatment is a significant lever to helping improve the outcomes of the patients that we see. So just to back up for a minute, let me describe briefly what is going on in Baltimore. Baltimore has a population just up the street, 650,000 people, of which 12% suffer from substance abuse. We have the unfortunate luxury of having heroin dominate the admissions into treatment. So 67% of all admissions, heroin is cited as their primary drug of choice. That's given us the ability to develop unique interventions targeted to one drug, one illicit drug, rather than be concerned about evidence-based practices across a wider range of drugs. In 2006, I was with the state prison system at the time, but Dr. Josh Oursteen, who's currently the Deputy Director of the FDA, really thought of buprenorphine as a potential to really make a difference in Baltimore City. So what was decided to create, and during my tenure we've expanded a great deal, is to set up a public health response to an individual disease. So let me tell you what that means. It means that whether you go into an outpatient program, into an ER, or into a detention center, that you should have the option of medication. The benefit of buprenorphine for us, which is different than methadone, which we're a big supporter of, is that we fund the substance abuse treatment for that individual for the first 35 days. We stabilize that person in treatment on average of 155 days. At that point, the person has health entitlement benefits, and their urines are free, drug-free, and they've begun to really achieve some substantial milestones in terms of their recovery. They then are transitioned to a continuing care doctor. So because of the comprehensive system of helping people get insurance, stabilizing them in care, and then moving to continuing care doctors, we're freeing up our financing, and we're also freeing up space within our treatment programs. To illustrate this, when I took over at BSAS, we had 112 buprenorphine spaces. We currently have 506. Through those slots, we have transitioned over 3,000 people to continuing care doctors who are getting their medications, and being treated for their other medical issues and mental health issues in federally qualified health centers and primary care physician offices. The best news of all is that 94% of those people, those stable people that we've transitioned to continuing care doctors, still remain in care after 6 months. So they now have health insurance, they're stable, they're in active recovery, and they continue to be in what we call a medical home, that primary care physician that's going to help look after all of their needs. And some of the stories, particularly from the panelists to my right, there are a great number of medical complications that frequently are related to addiction. And to be able to get someone placed in a place where all of those things can be taken care of comprehensively is just such a significant advantage. We believe that the way we're incentivizing care today has to fundamentally change. We currently fund episodic acute care. What we're interested in doing is creating new funding mechanisms that reward the referral, in other words, the emergency room, the detention center, or the drug treatment program, to refer somebody to another type of substance abuse care, and they should be financially incentivized as well. So instead of just funding one place with 4 walls and a roof, we want to fund the entire system and have the funding follow the patient. That's our buprenorphine initiative in a nutshell. Let me switch very quickly to my work in corrections. Prior to my starting at public safety in 2005, people regularly died in our detention center and prison of overdose. The single biggest period of overdose deaths is after someone leaves an institution and they go back and try to use the same dose of heroin that they did prior to their incarceration, or when they leave hospital stays. This is a significant challenge significant challenge in causing stress with correctional officers, institutions, and it's a public safety issue within detention centers and prisons, which is illicit drug use. So for us, what happened was in our detention center, we process within Baltimore City about 85,000 people. We now assess every single one of those people. Over 70% readily self-report that they have an addiction problem. We believe it's higher than that. But just that they would self-report it that's a substantial benefit. We then now induce people on methadone and detox them with methadone inside the detention center. And in the calendar year before I left, we detoxed 5,400 people using methadone and other drugs. People who get arrested on methadone were historically thrown off of their dose. We now maintain those individuals on methadone while they're incarcerated so that if they do get probation, if they are released on their own recognizance or make bail, they can return to their program without having to go through withdrawal. This has saved lives in Baltimore City. What we now plan to do in our next phase, which is one of the reasons why I wanted to come on board with in charge of Baltimore City, is I need to increase the infrastructure to absorb heroin addicts who come in because of a drug-related offense. We want to induce them, start them on buprenorphine or methadone, and have them leave the institution the same day, get medicated upon release, which then takes the significant pressure of withdrawal and the need to commit new criminal acts away from them. We think in doing this we'll make a substantial impact on the murder rate, crime, spread of HIV, and other things. By the end of this fall...
Could you wrap up your testimony?
Yeah, sure. This fall we'll have some research coming out that will help us determine if we've saved money with health care expenses deferred, recidivism rates, and otherwise, because we think we potentially have a story to tell. We just need outside researchers to come in and help us tell our story rather than us trying to tell our own story. But thank you for the opportunity to share.
Thank you, Mr. Warren. Mr. Hall.
Thank you, Chairman Kucinich. I am basically Mr. Warren's equivalent in Fairfield County, Ohio, which is a mixed rural suburban community that is adjacent to Columbus. To be completely honest, thank you. To be completely honest, I'm rather amazed at how common all of the themes are in terms of what people are talking about here. What I would like to discuss briefly is the scope of what I believe may be the most profound public health problem that has ever confronted our state, and what I think are some potential solutions to that problem. First of all, in terms of the scope of the problem, in 2002, approximately 4% of those persons in treatment for addiction disorders in Fairfield County were there for opiate and heroin addiction problems. By 2008, we experienced a pretty significant uptick. We were at 31%. 31% of those persons in treatment for addiction disorders in our county were there because they had heroin or opiate addiction problems. Last month, as of last month, almost 70% of those persons in treatment for addiction disorders in Fairfield County, in rural suburban Fairfield County, were there because they were opiate or heroin addicted. In terms of criminal justice statistics, 85% of our drug court participants are either addicted to heroin or opiates. Last year, in 2009, we completed a jail utilization study in conjunction with the Sheriff's Office. That covered 2 years, 2003, which was at the beginning of the heroin and opiate epidemic in our community, and 2008, which was towards the end. In 2003, we estimated that Fairfield County commissioners spent about $350,000 incarcerating opiate addicts. By 2008, 52% of all jail days were accounted for by opiate addicts. The total cost was $2.5 million. We also found that more than 90% of those persons who were incarcerated for opiate addiction problems were repeat offenders who had been in jail on an average of 5 previous times. Now, how could this have happened in Fairfield County, Ohio? Obviously, we have illicit pills coming up from Florida and Kentucky, which is a serious problem. We also have heroin coming down from Columbus. But one staggering statistic that I've just recently been able to come up with, I think potentially explains most of our problem. The Ohio Pharmacy Board reports that for the 4-county area of Fairfield, Athens, Hocking, and Perry counties, a region of 269,000 people, there were 13.9 million doses of oxycodone and hydrocodone dispensed legally across all of those residents. If every one of those 269,000 people received an average dose, that would be 52 OxyContins, Percocets, and Vicodins for every man, woman, and child that lives in Fairfield, Athens, Hocking, and Vinton counties. If you include propoxyphene and tramadol in among those drugs, the numbers raise to 20.1 million, or 75 doses for every person that lives in our area. Unbelievable. What works? For those people that have crossed the line and are now involved in our criminal justice system, we have found that 4 things work. A combination of drug court, intensive treatment, frequent random urine screens, and medication-assisted therapy using Suboxone. Suboxone is incredibly important from my perspective. It relieves craving without euphoria, and it displaces other opiates from the receptors. Now, what has been our experience? In the first 2 years of our drug court program that included all 4 of those elements, we were able to suspend 14,000 jail days at a savings of $910,000 to our county. And again, a combination of all of those 4 things. In closing, we are being overwhelmed in central and southern Ohio. The number of opiate and heroin addicts is staggering. We need more drug court capacity. We need more treatment, and we need more Suboxone. Thank you, sir.
Thank you, Mr. Hall. Mr. O'Keefe.
Thank you, Mr. Chairman. I'll summarize my testimony here and request that my full testimony be inserted in the record. I had the privilege of working with the National Institute on Drug Abuse in the Cooperative Research and Development Agreement, which resulted in the ultimate FDA approval of buprenorphine or Suboxone for the treatment of opiate dependence. This successful industry-government collaboration has resulted in the treatment of over 2 million people who might never have been treated for opiate dependence without the successful confluence of several factors. In the late 1990s, then Chairman Bliley, then Senator Biden, Senators Levin and Hatch, then Chairman Bliley and Hyde and Mr. Dingell, the Drug Addiction Treatment Act of 2000 was enacted. This act, for the first time in nearly a century, allowed effective agonist-based treatment for opiate dependence in patients in the privacy of the offices and clinics of qualified physicians. These congressional leaders recognized the significant inadequacies of the highly regulated, closed addiction treatment programs, which had grown out of temporary regulations, temporary fixes begun during the Nixon administration, and regularly expanded, often at the behest and to the delight of many of the closed system treatment providers since that time. These congressional leaders understood the stigma associated with addiction. They recognized that unlike cancer, AIDS, diabetes, hypertension, there were no patient advocacy groups to encourage better treatment. They recognized that despite the fact that nearly every one of us knows or is aware of a family member or friend devastated by this disease, seldom will we talk about it, much less advocate for better research on its causes and treatments. These congressional leaders recognized that the pharmaceutical industry had little interest in spending scarce research budgets for products for a disease whose patients were often unemployed or underemployed, often had no insurance and no other medical coverage or ability to purchase these products. These leaders recognized that many rejected or failed to fully comprehend the increasingly validated findings of the scientific community related to this disease. They understood that many believed that addiction was simply irresponsible behavior which should be punished. They recognized that some of these same attitudes also permeated into the structures of medicine, academia, and government. Yet despite these barriers, the leadership provided by the Biden, Levin, Hatch, Bliley, Hyde, Dingell consortium insisted on better treatment. Despite the reluctance, sometimes intransigence, of the Food and Drug Administration, despite the expressed concerns of the DEA, despite the objections of entrenched commercial interests, despite the clear lack of enthusiasm of ONDCP, the 106th Congress passed the Drug Addiction Treatment Act unanimously in the Senate and 412 to 1 in the House. Thus began a paradigm shift in the treatment of opiate dependence in the United States. And we all relaxed, and that was a mistake. The barriers to development of products to treat addiction are still in place. Medications for addiction treatment are of little interest to the pharmaceutical industry because there is no incentive to commit scarce R&D funds to development of products unlikely to provide a significant return on that investment. The insufficiency of contract funds available to the National Institute on Drug Abuse limits their ability to engage in development activities suitable for FDA submissions. The failure of FDA to take a position on what constitutes efficacy in clinical trials for addiction is a major deterrent to investment in research on these products. The stigma of addiction and the fear of DEA leads many physicians to avoid treating this disease despite the fact that many of their patients suffer from it. Medical schools are providing inadequate training and treatment for this disease. Stigma prevents patients who suffer from it from seeking treatment. Additional and perhaps safer medications for the treatment of opiate dependence could probably be put in the hands of qualified providers within a year, except for the expressed lack of interest of the Food and Drug Administration and the less than helpful interpretations of the Controlled Substances Act by the DEA. For the benefit of millions of patients who need addiction treatment, I suggest that now is an appropriate time for the Congress to consider options which might encourage the commercial pharmaceutical industry to invest in research for safe and effective treatment of addictive disease. Among those options which seem to me worthy of consideration by the Congress are the following. Some modification of the Orphan Drug Act to provide exclusivity for products approved by FDA for this indication without regard to patient numbers. Perhaps a modification of Section 524 of the Food, Drug, and Cosmetic Act, which was created last year by the FDA amendments 2 years ago of 2007, by authorizing the FDA to issue a priority review voucher for addictive diseases. Or an exclusivity voucher similar to one proposed by then-Senator Biden, allowing a sponsor of an approved addiction treatment product to transfer a period of exclusivity to another marketed product. And finally, perhaps a modification of Section 48D of the Internal Revenue Code, which would allow qualifying companies to claim a tax credit or receive a grant for qualifying therapeutic addiction treatment discovery projects. Thank you, Mr. Chairman.
Thank you, Mr. Pops. You may proceed.
Thank you, Mr. Chairman, distinguished members. Thanks for inviting me here today. I'm the CEO of a biotech company called Alkermes, with about 600 employees, 300 of which are in the Boston area and about 300 of which are in Ohio. We, as a biotech company, are engaged in the act of typically focusing on treatment of diseases that the large pharmaceutical companies shy away from. And in our case, this includes the treatment of addiction. So it's really our real-world experience as one of the few companies working to develop medications in this area that brings me here today. With original seeding funding from NIDA, our scientists created a drug called Vivitrol. Vivitrol is a once-a-month medication. It's a non-addictive medicine administered by injection once a month, which relieves the patient the need to take one or more pills one or more times a day. And as you may know, taking daily medication for patients with addictive disorders is extremely difficult. Vivitrol was approved by the FDA for the treatment of alcohol dependence in 2006. And with that approval in hand, then we set out on a research program to demonstrate Vivitrol's potential utility in the treatment of opioid dependence as well. That was very successful from a clinical standpoint, and we're hoping for FDA approval in this indication later this year. We began our work at the molecular level by trying to understand the neuroscience behind addiction. With our successes in the lab and in the clinic, we end up here in Washington with you with a deep interest in advancing the public policy so that our innovations actually get to patients. You're aware of the statistics, and I won't repeat many of them, but they're staggering. Millions of Americans with addiction are underserved or untreated and don't have options and access to the important treatment options. If you compare the use of medicine for the treatment of depression to that of alcohol dependence, it's instructive. The rate of medication prescribed per covered life for depression is almost 1 in 10 for antidepressants. And that compares for alcoholism to less than 1 in 5,000. The system in the U.S. bearing the largest economic and public safety brunt of alcohol addiction is criminal justice, where 40% of all violent crimes involve alcohol. And despite this prevalence, over 80% of addicted offenders fail to receive treatment for their disease. So in addition to this being bad medicine, it's bad economics. These untreated patients are costing the system billions of dollars, as you know. That might have been understandable 30 years ago, when the scientific understanding of the addicted brain was at its infancy. But today, knowing what we know about the neuroscience of addiction, the failure to use medicines is inexcusable. With the FDA now having approved medications based on rigorous demonstration of their safety and their efficacy, and with the NIH and the Institute of Medicine calling for their use in combination with counseling, it's now time for society to begin to treat substance abuse as the diseases that it is. This work at Alkermes has become very real to us. We receive letters and stories from patients who've benefited from the use of Vivitrol as part of their treatment program, and they're incredibly moving, and they're a driving motivation within our organization. But we are definitely in the minority. The treatment of addiction is not a mainstream pharmaceutical market, as you've heard. None of the largest pharmaceutical companies sell products for the treatment of addiction. But I believe this can and will change. Government can help, and in fact, I believe the government policy changes are likely necessary to solidify the development of new medications for alcohol and drug addiction. We have specific recommendations that we summarize in the written testimony, but in just brief nutshell, there's some simple and powerful things that can be done. First, simply implementing established treatment standards like those of the National Quality Forum and make them a condition to participating in public and private programs would be a huge step forward. These standards exist. Number two, providing grants and incentives for states to assist them with establishing addiction pharmacology programs. Third, simply using performance-based metrics, like you hear about in Baltimore and in Ohio, to fund programs that work and accredit providers that use those programs that work. And then finally, an even more aggressive idea, similar to what you did with vaccines, is to jumpstart the market with guaranteed minimum purchase orders for a limited period of time. These kinds of initiatives represent ways that government leadership can help patients gain access to effective medications, create incentives for companies to invest in R&D, and avoid the huge costs of non-treatment of these patients. So I'll finish there. We really do believe that state and federal governments can play a role here and begin to bring the promise of the modern pharmaceutical research that we do in our company and other companies, bring that to the treatment of addiction. Thank you again.
Thank you. We're going to we'll move on now to questions of the second panel. I'd like to begin with Dr. Samet. Some in the substance abuse treatment field reject the use of addiction medications as substituting one drug for another. What is your medical opinion about this?
Medications for addiction can be of the type that are agonists to the receptors, where the term of substituting the drug, or not, often antagonists. The evidence is that both types of medications are effective. That's the data. To say otherwise, I would say, is the entering of stigma into the evidence for treatment.
And so how do we destigmatize addiction and bring into mainstream medicine? How can we do this in a way that gets the benefit of medications in the way other chronic diseases are able to do that?
I think we can do it by pushing the concept of evidence-based medicine. I think that's happening. I think when I began on faculty of a medical school 20 years ago, it seemed like a distant goal. I think it's happening right now. So what you're saying needs to happen is happening. It just has to be accelerated. It's very possible. We've seen it.
Now, Mr. Warren, you testified that the total annual cost to operate the Baltimore buprenorphine initiative for 2009 included funding for medications, outpatient counseling, physician, nursing, treatment advocate staff. That total was, I think, $2.8 million. Now, it seems like a lot of money, but you've testified that with the use of buprenorphine, you have reduced the period of stabilizing patients and transferring them to outpatient programs from 281 days to 155 days, enabling you to treat more patients. So is this program cost effective?
We have found it to be hugely cost effective. For us to maintain that particular person on their medication and in treatment forever and ever and ever would be mind-numbing financially. What we're able to do, though, is realize what is out there now in the healthcare system, utilize the block grant to fund people who are truly uninsured, help them get insurance, and then once they get medical assistance, they then move to that pool of funding, which the state of Maryland then brings in 61 cents for every dollar. So for us, we're able to treat 3 to 4 times as many people than historically we would, simply because we're trying to optimize the public health system to the fullest.
Now, Mr. Hall, has Fairfield County, Ohio, found it cost-effective to pay for these medications as part of a drug court program? And have you been